Welcome to Ebola virus disease for EMS. The objectives of this program are to discuss Ebola virus disease's history, pathology, the history of the current Ebola outbreak, challenges to containment, precautions, EMS-specific guidance and DES actions, and decontamination. Ebola was first encountered in 1975 in the Sudan, near the Ebola River in West Africa. Over 250 people were infected, with a mortality rate of 53%. A second, more serious outbreak occurred in 1976, with over 300 infected and a mortality of over 88%. In 1989, there was an outbreak in Reston, Virginia, which is called Ebola Reston, that infected hundreds of monkeys imported from the Philippines. Staff at the facility were found to test positive for the virus but displayed no symptoms. This confirmed the ability of the virus to transmit between species. In 1994, a zoologist was performing research was infected while examining a dead chimpanzee. This reinforced the idea that the virus survives in dead organisms and has the ability to be transmitted through those dead organisms. At this point, there is no empirical evidence supporting the concept that this virus is airborne. Pathophysiology. Ebola virus disease is part of the Filoviridae family of viruses. They characteristically have a long monofilament structure, and they attack the host by attaching or binding to a cell. And infecting the cell. Once enough copies of the virus are made inside the new cell, they leave the dead host cell and attach to other new cells to repeat the process. Ebola virus disease prefers endothelial cells in blood vessels and GI tracts, which is why it is a hemorrhagic fever and causes so much bleeding. It also attacks the immune cells, which makes it much more difficult for the body to fight the infection. The incubation period is currently thought to be 2 to 21 days. The initial presentation includes flu-like symptoms, headache, fever, malaise, and progresses to confusion, seizures, and multi-system organ failure. It can also result in bleeding from the eyes, nose, and mouth, a rash and blisters all over the body in late stages. Treatment. Presently, there is no known cure. There are many different experiments being conducted, including experimental medications. There is a urgent antivirus vaccination program currently being explored. We have discovered that blood transfusions from survivors appear to be helpful, and in fact, the nurse that's currently infected that was in Dallas and is being moved to the National Institutes of Health has already received a blood transfusion because the survivors develop antibodies to the virus. Primarily treatment consists of supportive therapy, including ventilatory support, hemodialysis, and fluid replacement, as well as antipyretics. The current outbreak has approximately 10,000 infected victims identified. Due to the nature of this outbreak, it is very difficult to determine what the true number is. In remote villages and areas of some of the third world countries that are involved, it is extraordinarily difficult to get an accurate count. It appears that patient 0 from this outbreak was a 2-year-old in Guinea who died in December of 2013. The epidemiological investigation reveals that the Ebola virus disease spread slowly through the family until March 2014, when the Ministry of Health in Guinea finally acknowledged that the outbreak existed and welcomed assistance from the CDC and the World Health Organization. The current outbreak can be found in 3 primary countries: Guinea, Sierra Leone, and Liberia. During the summer, the outbreak did spread. Medical workers from around the world have rushed to provide assistance. There are many different cultural challenges to containing the spread of the virus. Many parts of that world, when there is a death, the family members take the body and wash it prior to either cremation or burial. The problem is that at the time of death, the virus is most contagious and concentrated and causes other folks to become infected. The other is fear of quarantine has led to an enormous reluctance amongst some of the indigenous populations to report any disease. There have been a few cases of Ebola virus disease in the United States. Dr. Kent Brantley and Nancy Rateball were the first cases to be treated in the U.S. Both were infected while treating patients in Africa and were subsequently flown to the United States. Dr. Brantley to Embry University in Atlanta, the other two, Nebraska. One person has been admitted to the National Institutes of Health, and very shortly others will be added. The first non-condoned, so to speak, case was a Liberian national, Eric Duncan, who traveled from Liberia via Brussels, Belgium, to Dulles International, and ultimately to Dallas, Texas, to visit family. He has subsequently succumbed to the disease. As of October 15th, there were 2 healthcare workers who have tested positive. Many other workers are being monitored. The individual being pictured here is actually one of the nurses who cared for Eric Duncan initially in the ICU and was monitoring herself at home. She is being transferred to the National Institutes of Health from Dallas. As mentioned earlier, the incubation period of the virus is 2 to 21 days before symptoms appear, and that was originally thought to be a non-contagious period, although questions continue to persist whether that's an accurate statement. Indigenous populations at the source of the outbreak may be contributing to their spread by the washing of bodies as part of their funeral rites, staying home and caring for multi-generational home families, and failing to report illnesses or contacts with those who had illness. For example, Eric Duncan, the Liberian who traveled to Dallas, had at least 4 opportunities to self-report contact with potential Ebola virus disease patients and did not. Another challenge is, as patients become more ill, they can become more contagious. Precautions. Very simple. Utilize good aseptic technique at all times. Wear and utilize universal precautions at all times. Screen patients for inclusion or exclusion from the enhanced procedures that we'll discuss later. Heed the advisories provided by radio from the Department of Emergency Services. And clean all equipment and vehicles with the antimicrobial and/or antiviral materials as frequently as possible. Department of Emergency Services will continue to ask questions of callers, much in the same way that they have for many years. Does the patient have a fever or feel feverish? Does the patient have a cough, runny nose, sore throat, or any recent onset of respiratory difficulty? If the answer to both of those questions is yes, then DES will responding units. Enhanced precautions are indicated. This is slightly different from the original respiratory precautions advised. If the response to the fever question is yes, then a third question will be asked. Has the patient, or anyone the patient is known to have been in close contact with, traveled to West Africa in the past 21 days? A yes response to that question, as well as the fever question, will generate an advisory of enhanced precautions are indicated and positive travel history. These questions are based on the current CDC guidance. If that guidance changes, further updates will be provided to reflect the most accurate guidance. If you hear the enhanced precautions are indicated and positive travel history, it is strongly suggested you be prepared to don your protective equipment. If a patient presents to you with flu-like symptoms, headache, nausea, vomiting, diarrhea, muscle pain, abdominal pain, or unexplained bleeding, and has a fever of 100 greater than 101.5, you should ask if anybody they know have traveled to Liberia, Sierra Leone, or Guinea, or had any contact with anybody who has Ebola. If yes to those, immediately don your protective equipment and summon additional assistance. Upon receipt of the DES advisory or other positive indications that enhanced precautions are required, crews shall don their appropriate PPE, which will include gloves, fluid impervious gown, eye protection and face shield, and surgical mask. Additional PPE may be required, especially when there's large amounts of blood or body fluids. Patients should not be placed in an N95 mask, but a normal surgical mask is recommended. Crews should wear N95 masks whenever performing any skills where aerosolized body fluids may be present, such as intubations, suctioning, or CPR. Use strategies to reduce potential exposures by wearing more than one pair of gloves or double gloving, minimizing or eliminating the reaching into cabinets without changing your gloves. When double gloving, maintain the inner gloves as a safety net, so always use the inner gloves as the safety net. Place other gloves on top of them before you touch anything else. Avoid any contact with surfaces that can spread potential contamination, electronics, doors, counters, etc. If operating in that manner, utilize assistance to do those things. Remove PPE without assistance or removing PPE without assistance. Hospital staff, if we're transporting a patient to the hospital, will be happy to be able to assist you and help us reduce our cross-contamination and go through the contamination procedures. Patient's family should not be transported in the ambulance if at all possible. Advise the family to stay at home and contact the hospital via phone for further instructions. If they will not comply or must be transported, i.e. there's a small child or some other need to bring them with them, they should be transported in the patient compartment. If traveling in a personally owned vehicle, they should be directed to park in the ambulance area so they could be greeted by hospital staff and any additional risks assessed. When transporting a positive screened patient, contact the hospital via normal notification methods, i.e. 220 or Medcom. Advise the hospital that you have a patient with enhanced precautions and or a positive travel history. Provide the normal clinical information and advise them if any family members will be arriving and by what method and entrance that they will be arriving. Remember that they should be directed to the ambulance entrance of the hospital emergency room whenever possible so they can be greeted, separated, and screened as quickly as possible to reduce risk of contamination if need be. Upon arrival at the hospital, all linens and other materials that came in contact with the patient shall remain with the patient, because if the patient screens positive for Ebola, those biohazard materials have to be handled in a different manner and disposed of differently than traditional waste. Decontamination. When decontaminating, again, wear the appropriate PPE, masks, gown, gloves, face shield, and use an appropriate solution. Cavicide, which is a product we carry in our stations and trucks, will kill Ebola. Remove any gross liquids, large puddles of blood, etc. Wipe down all non-porous surfaces after being sprayed with the cavicide. Contaminated materials shall remain with the patient. Again, those materials must remain with the patient because they require special handling. Additionally, you should and can Use the resources available at the hospital for guidance and assistance in decontaminating your vehicles. Other items. If you encounter a patient who meets these criteria, ensure that the on-duty supervisor is advised. Both hospitals in Berks County, the Department of Emergency Services, and management are monitoring the CDC guidance for changes and updates. If there are any significant changes, we will push the updates electronically as soon as possible. Quickly, there are 2 cases of transmitted Ebola virus disease in the United States. There are 317 million people in the United States. That means that the percentage of the infected people in the United States is currently 6.3 times 10 to the negative 7%. If you contrast that against the number of people who died from influenza, that is 8.8 times 10 to the negative 3, a much larger number. There were approximately 30,000 people who died from the flu last year. Ebola virus disease is very dangerous, but if we maintain vigilance with accurate patient interviewing and surveying and appropriate universal precautions,